Welcome to part 3 of ECG Made Easy. Let's talk about the P wave. Now, the P wave, it represents the atrial polarization. It's up to 3 small squares wide, positive in lead 1 and 2, negative in lead R, and biphasic in V1. What do you mean by biphasic? We'll see. Now, in conditions that enlarge the right heart due to mostly pulmonary disorders or disorders of the right heart, you got a tall peaked P wave that is more than 2.5 mm. It's called a P pulmonale. If you get a biphasic P wave, your P wave goes up and goes down, and negative deflection is more than 40 milliseconds wide and 1 millimeter deep, small box. It is a sign of a left atrial enlargement. If you got P mitral, it's like an M. It's often bifid. It's usually due to left atrial enlargement due to mitral stenosis. The PR interval, as we mentioned, start of the P wave to the start of the Qrs complex. It's usually 3 to 5 small squares, and it can be short in conditions such as WPW syndrome. These are MCQs. And a long PR interval may indicate a heart block. Let's go through them. In a first degree heart block, the PR is longer than the normal, but every P wave follows a QRS complex and it is constant. The PR interval is constant. In type 2, second degree heart block, type 1, you've got a PR interval that is normal, but you get with a fixed duration PR interval lengthening followed by a skip beat. So if you see in the first beat that we see here, the PR is smaller, it's bigger in type 1, bigger in the next one, and you skip it in the fourth. So it's a 3:1 pattern of Mobitz type 1. In a Mobitz type 2, the PR interval does not lengthen, but you get a skip beat nonetheless. So you see right here, you've got a beat, then you've got a P wave coming, but a skipped beat. You've got a P wave, a beat, P wave with QRS, P wave with none. So the PR interval does not lengthen, it stays common. It's Mobitz type 2. In a third degree heart block, there's no relationship between a P wave and a QRS. It doesn't travel. So you got P waves that are not related to QRS, and QRS that is maintaining a fairly ventricular rhythm. Short PR interval is present in WPW. It's a really important disease to find out. You'll also see in the question of WPW a delta wave or an upslope of QRS complex. Let's talk about the QRS complex now. Now, usually the Q wave is less than 1/3 of the QRS amplitude. So the maximum R to the minimum S, the distance between them, the Q wave should be less than 1/3 of this distance, and it is usually increased in amplitude due to cardiac hypertrophy. We'll discuss this in detail in a little while, and usually it is less than 3 small squares. QRS can help you find bundle branch blocks, and I love explaining this. William and Morrow. William starts with a W, has 2 L's in the middle and M in the end. So it's 2 L's in the middle stand for left bundle branch block. William, W in the lead V1, M in V6, left bundle branch block. Small r, SR, monophasic RS pattern. Now, in a right bundle branch block, you remember Morrow. Morrow has M in V1, W in V6, and double R stands for right bundle branch block. It's a small r, capital SR pattern, and slurred S wave in 1 and V6. So William for left bundle branch block and Morrow for right bundle branch block. So these are the condition in which usually you can have a tall R in V1. I like to mention V1 usually has, if we have around here, V1 usually has S wave that is bigger than the R wave, and gradually as you move towards V6, the R wave gains in size and the S wave becomes smaller, and around V3 to V4 these become equal, and V5 and V6 R wave is bigger than the S wave. But in these conditions you can have a tall R wave in V1. Let's talk about left ventricular hypertrophy and right ventricular hypertrophy. To find these out, you need to calculate the MMs of even the left ventricular hypertrophy. This criteria, the Sokolov and Leon criteria, in V1 the size of S, that is the maximum deflection, and V4 5 or 6 size of R. You add these up. If it is more than 35 millimeter, you've got yourself left ventricular hypertrophy. An example is here. You see the tall QRS. In V5 you've got a big R wave, and you add them up with the V1 S wave, you get more than 35, and you've got a ventricular hypertrophy, left ventricle. This is inverted T, is strain pattern. We'll deal with that later. Now if you're calculating the right ventricular hypertrophy, you'll get a right axis deviation. In V1 you will get a tall R more than S, and V6 you'll get an S more than R. These are causes, you can learn them. Now the most important part, ST segment. ST segment is usually isoelectric. It's at the center line. It's at the same level as the subsequent TP segment, so around here. So this line represents where it should be. It's usually 2 to 3 small squares. It can help you identify ischemia and infarction. Now you need to learn this, the affected arteries and the changes in ST segments. If the location of MI or ischemia is in the anterior wall, V3 and V4 will have the changes. Anterior descending artery will be effective. There's a septum, V1, V2, left anterior descending, left lateral. Now you need to learn all these. Inferior is a common question, 2, 3 AVF. Common question. The important thing is changes will be present in all the particular leads. So if, for example, if there is an inferior wall MI, you will have changes in 2, 3 AVF. If it's an interior, you will have in V3, V4. This is important. Now the criteria around here, it's been a little changed. Let me remind you. Now an ST segment elevation in any lead except V2 and V3 of more than 1 millimeter is significant, and ST segment elevation of more than 2.5 mm in ages 40 or less in males, 2 mm in 40 or more of males, and 1.5 mm in any age female in V2, V3 are significant. That is the elevation. So let's get to ST elevation. This is how an ST elevation looks like at 0R. You see the ST segment is above the isoelectric line here, and the J point I remember mentioning is the end of the S wave and start of the ST segment. It's also raised from the isoelectric line. Later on it changes its form. T wave becomes inverted, and at the end you find a Q wave that is present, pathological Q wave. Now the ST segment, for example, right here in V2, V3 you see more than 2 mm ST segment elevation. It's a STEMI. ST segment in 2, 3 AVF, and reciprocal changes in V2, V3. Reciprocal changes means that this elevation in V2, 3 and AVF has produced depressions in ST segment in V2, V3 in the anterior leads. Now this is an inferior wall MI. In NSTEMI, usually you've got a T wave that is inverted. Myocardial infarction, non-ST elevation. The ST might be depressed. Difference between ischemia and this is the troponins or the cardiac enzymes are positive in infarction and not present in ischemia. So if it's negative, it's unstable angina with chest pain. Here you can see again the leads will be the same. If it is present in lead 2, 3 AVF, it's inferior wall end STEMI. If it is present in 1 AVL, V5, V6, it's lateral wall. So similar. And mostly an ST depression shows you about myocardial ischemia, then infarction, but if the enzymes are positive, it is an NSTEMI. In pericarditis, you get a saddle-shaped, concave-shaped ST elevation. It is seen in all leads and not the leads in which ischemia is present only. So like a saddle in a horse, you can identify this pattern. It's present in most, if not all, the leads. So acute pericarditis, the question of acute pericarditis will also have a characteristic history that the patient feels a little better sitting forward than lying down. In digoxin, you will get a question reverse tick sign. Check this. Now it's like a Nike sign, but just to the other direction. The ST depression and T wave inversion you can see here. About the QT interval. Now the most important thing is for you to learn long QT syndrome. It is a heart condition. Repolarization of heart is delayed. These are the causes. Okay, let's talk about the T wave. A normal T wave is rarely exceeding 10 mm. It can be tall, peaked, biphasic, or inverted. If it's abnormal, it's usually upright in leads 1, 2, and V2 to V6. So it can be normally inverted in 3, AVF, AVR, and AVL, and V1. That is where it is usually variable, but it's always inverted in lead AVR. So how will you find out if this MI going on? You'll have all the leads of a particular heart area will have the representation of inverted T wave. Now these are different types of inverted T waves, very important. In acute coronary syndrome, you'll have symmetrical T wave inversion. The down will be equal to the up. In subarachnoid hemorrhage, you will have deep T wave inversions. In left ventricular hypertrophy, you'll have a strain pattern. The down slant will be less than the up slant. In digoxin, you will have the reverse tick sign. In juvenile T pattern, you will have kind of symmetric pattern. This usually, Wellen syndrome usually does not come in the examination, but you can read about it. A U wave is present after the T wave. It's upright and it's positive mostly in lead 2, same direction as T wave in the previous in that lead. It is most often seen in hypokalemia, but may be present in hypercalcemia, thyrotoxicosis, digitalis, epinephrine, and intracranial hemorrhage. Now U waves are really important, usually associated with hypokalemia. Other ECG signs, hyperkalemia would be tall tainted T waves. You can't sit on these T waves. These are tall tainted T waves of hyperkalemia. If it becomes even more than 7, then the Qrs complexes widens. It makes the appearance of a ventricular tachycardia, but it's mostly because of the potassium. You've got to treat this immediately. And heart arrest if it reaches 9. U wave in hypokalemia you can see, and T waves become flattened first. U wave comes, ST depression, and T wave might be inverted. And these changes are not related to degree of hypokalemia. A low voltage ECD, these are the causes. QRS is less than 5 mm. So in fat people like me, you can have a low voltage ECG. Thank you so much. I hope it helped. Share and subscribe. If there's a question, you can always ask me in the comments.